Morning, everybody. It's a great day to be alive here in Minnesota and to share some time with y'all on some pretty important things. I'm not going to spend a lot of time on this kind of banter. We need to get to work. I would like to get this done in 30 minutes or less. We'll see how that goes. This is what we're going to do today. Actually, I've added one thing. First of all, an overview of House File 3 that creates ONEcare and other serious things. I can't understate that. Um, just a quick note about the sick tax debate. As you all know, the sick tax, the 2% tax on healthcare services, expires in 2019. The DFL House and the DFL governor have included the sick tax in their budgets to add almost $1 billion to fund Minnesota Care. The state Senate, which is Republican control, is fighting this. In fact, Jim Abler was the author of the bill in the House that terminated or sunsetted this tax, and now he's a state senator. It's really hard for me to think that the state Senate is going to capitulate on this, at least in the way that we know it now. One of the big complaints of healthcare providers is that each year they have to, or each quarter, whenever, however often they pay, that they have to come up with this big check and send it into the state. And they don't like it. They feel like it's coming out of their pocket. And they feel they were misled on it and that it was going to be actually paid by the insurance companies. It may be, when this is all said and done, that somehow there'll be a compromise and there'll be a way for insurance companies to pay the sick tax. I personally, it's like I believe in user fees. User fees on sick people seems a little insidious, but we do have to pay for these things, and we're going to pay for it one way or the other. I think agents are going to have to weigh in on it, give it more discussion and thought. The other thing we're going to spend time on is the alternative to ONEcare and other serious things. More transparency and reference-based pricing. So let's get to work here on the bill itself and how to retrieve it. I'm going to exit and bring the bill up rather than have a whole bunch of slides on it. So this actually is the bill itself, House File 3. You'll want to go out and retrieve that for yourself, and I'll show you an easy way to do that in a minute. Let's breeze through it so that you know, if you will, the highlights of the bills. If you've never read a bill, this is a little bit of instruction in how to read a bill. I've had the displeasure of reading many bills and actually writing several of them. So it says it's relating to healthcare, establishing the ONEcare buy-in, establishing outpatient, pay attention, prescription drug program, modifying provisions governing dental administration and governing healthcare. That's a summary of what the bill does. I've highlighted several sections. I hope this doesn't make you seasick with me going through it. Notice under dental services, the first thing I've highlighted is contracting for dental administration services, putting the state in the position of actually being a contractor for dental health care for certain categories of people, those certainly on Minnesota Care and medical assistance, as you see here. You'll see that's a theme that runs through the bill, the state taking over management of certain aspects of health care. This particular passage says that any vendor of medical care, anybody that provides medical care, look at this, must participate as a provider or contractor in the medical assistance program in Minnesota Care. What this means is if you are a medical provider and you provide services to employees who are on the state employee health plan, that you will also be required to take medical assistance and Minnesota Care patients. This is how they lock the doctors in. This clause kind of caught me. I just was looking at it this morning, that they have to also accept medical assistance and Minnesota Care patients And look at, they even have a set aside in the practice. At least 20% of the provider's patients would be covered for medical assistance in Minnesota Care. So it seems to me what they're saying is if you're going to accept the state employees as a patient, then you're going to have to also have at least 20% of your patients come from medical assistance in Minnesota Care. You all know that Minnesota Care pays and medical assistance pay at the Medicaid reimbursement rate, which is below cost. So this is very, very significant. We wrote about at MEEDAH the 87% hidden tax. That money that you pay for private healthcare coverage and private services is what helps to fund this. It offsets the losses for medical providers. So this is all connected to what you do. This one says, a vendor of medical care as defined in 256B, anyway, that dispenses outpatient prescription drugs must participate as a provider or contractor in Minnesota Care. So, and also in medical assistance. So they're forcing participation. You'll see that even includes the pharmacies as we go down. There's a lot else in here to be concerned about. I'm just skipping through to some that I thought was particularly of interest to y'all. Outpatient prescription drugs. They are adding outpatient prescription drugs to Minnesota Care, and you'll see actually it'll extend to other things. As I understand this, this is going to create a Minnesota state-run outpatient prescription drug program for Minnesota Care that I believe will also extend to other health plans eventually. The commissioner can modify the formulary. So you see who's going to be in charge of this outpatient prescription drug plan for those on Minnesota Care. Quite sobering. The commissioner can negotiate drug rebates or discounts directly with a drug manufacturer to place a drug on a formulary, not going through PBMs, but directly negotiating a drug outpatient plan. This requires pharmacies to participate if they want to provide pharmacy benefits for state employees. They're going to have to do this. It may even extend beyond that. And then here we go with the reimbursement rate. Hold on, I'm getting to the other stuff. It's coming up real soon. The basis for determining the amount of payment. So what this is saying is the state is going to determine the amount of the payment, and it's based on a formula. The national average drug acquisition cost, a dispensing fee, and so on and so forth. The point here is I just want you to see that they're determining the formulary, they're determining the reimbursement price, they're requiring participation by providers. All right, here we go. The Minnesota ONEcare buy-in. The commissioner shall establish a program consistent with this section to offer products developed for the ONEcare buy-in through the MNsure website. Key things here. The commissioner shall establish a program. This is a state insurance program to offer products for ONEcare buy-in through what? The MNsure website. So it's a state-run program that's accessible only through the MNsure website. They are going to use this new program to establish cost allocation to reimburse MNsure. MNsure's budget, early budget number forecast was going to $55 million, something like that. And it counts on these plans coming online eventually, by the way. These mechanisms must minimize adverse selection, state financial risk and contribution, and negative impacts to premiums. This is kind of humorous because the way that this plan will roll out, as you'll see in a minute when we look at reimbursement rates, is, I'm going to check, by the way, I think maybe there's a couple of, nope, I'm not going to do that. I'm all alone here running this, so I'm trying to do everything. It's supposed to minimize the negative impact of premiums in the individual and group health insurance market. Well, when they reimburse at the prices are going to reimburse at, and they don't have to have a statutory reserve system in place, you know that the premiums are going to be significantly less than what private insurance premiums can be. And it says here then that the commissioner is going to establish the per enrollee monthly premium rate. Here we go, rates to providers. The commissioner shall establish rates for provider payments that are targeted to the current rates established under 256L, which is the Medicare, Minnesota Care system, plus the aggregate difference between those rates and Medicare rates. And I take this to mean that the rates that the new ONEcare plans are going to be paying to providers is no more than Medicare. Without the 187% premiums paid in the private system, that would collapse. But if the premiums for the new ONEcare Platinum health plan are significantly less, they're going to compete with private insurance. This is about the reserve. There's an initial ONEcare reserve, claims reserve set up using state money. I think the number I heard was a little over $100 million. Then there is no reserve requirement built into this. The same reserve requirement that is required for private health plans doesn't exist in this program. That will affect rates. The plans have to offer essential benefits, just like qualified health plans, plus dental, plus vision. Could be operated by a third-party administrator. Now, I'm not going to go through all of these, but what you'll recognize as you watch them fly past is these are the same things that insurance companies do today. I especially highlighted number 4, processing premium payments and sending termination notices, and payment and adjudication of claims. These are the things that, again, that insurance companies do that this new state-run program is going to do. A person who's determined eligible for enrollment in a qualified health plan, you all know what that is. I'm talking to agents today and brokers and consultants. Person who's determined eligible for enrollment in a qualified health plan with or without advance payment of premium tax credits, with or without cost-sharing reductions, is eligible to purchase and enroll. What that means is if you qualify income-wise for ATPCs and cost-sharing reductions, or if you don't, you still are eligible to enroll in this. And then you'll see later that you could possibly, based on your income, still qualify for APTCs and cost-sharing reductions. So they get the best of both worlds. You get everybody, those who are eligible, those who are not eligible, and if you are eligible, you'll get the APTCs and cost-sharing reduction. I thought this was particularly enlightening. I wondered if a revisor staff put this in here. It requires legislators to enroll in the ONEcare buy-in program. Essentially, that's what it says. Fascinating, huh? And then the products. The Commissioner of Human Services shall establish a ONEcare buy-in coverage option that it provides platinum level of coverage. Platinum level means essentially no copays or low copays, very low deductibles, and 90% actuarial value, meaning that at least 90% of the premium has to go to pay claims. All right, that's an exceptionally good program that not many people have available to them right today. In fact, I understand it, there isn't a platinum plan available in the individual marketplace. I could be wrong about that, but that's what I understand. So this is a platinum plan that pays doctors and hospitals at the Medicare rate, does not have a reserve requirement, and by the way, cuts agent. Silver and gold products will be made available in areas where there are no silver or gold products right now. In other words, insurance companies are either going to have to come up with something for every area, or the state will have product that it offers. That obviously is a great concern. The Department of Human Services, by the way, specifies is not an insurance company. Now, effective date. Yesterday, I was talking with an agent, actually a consultant, and I was saying how we were going to talk about this, and he said, well, you know, this doesn't kick in for a long time. Well, wait a minute. I remember 2010, 2012, 2014, 2013 in particular, getting ready for MNsure to roll out and for the Affordable Care Act plans. I mean, that time really went fast. Those of you who've been agents for a long time, you know, 2023 is around the corner. And if this thing passes, if it did pass, as it is right now, you'd start planning your new career. At least the single payer crowd with their Minnesota plan allocates money to retrain agents. I'm not being snotty here. I'm just saying this is a very, very serious issue for you. This allows the commissioner to administer the outpatient prescription drug program. And then studying the cost. This is a study set up to study to see whether or not they should expand Minnesota Care as well, providing individual and small group health coverage. That's pretty interesting, huh? That's why they need to get the sick tax passed in order to support this. Now, there was some chats that came in. Let me just see. Yeah, there's no, okay, thank you. All right. I won't go into that now. How you can retrieve the bill. Oh, I'm going to get back on the slide thing here just a minute. Come on up. Okay, here we go. There's a lot of ways to retrieve the bill, but I'm going to show you one that we put together here on the MEEDAH website. We created an agent's page. Actually, if you look at if you can see the top, the URL, it's MEEDAH.com, actually MEEDAH.org/agents, but this page is available. Oh, I know why it's weird. Okay, I'll tell you that in a minute. Sorry I've been so candid. I'm learning about my own website here. But this agent's page is designed for you. And we have put up in here several documents, the Leave Behind flyer on the hidden tax, a hidden tax article. But here's the ONEcare legislation. If you want to retrieve this, you can go to MEEDAH.org, and down at the bottom of the page, you'll see this. We kind of hide it. We don't want the general public to see it. But when you click on it, then you'll be able to get to these articles. So that's why we did that way, a special thing just for agents. Or you can go on the legislature's website itself. You can retrieve any bill there. Just quickly, House File 3 has a journey. It was introduced several weeks ago, started in Health and Human Services. It passed out of there and went to the Commerce Committee. It passed out of there and went to the Ways and Means Committee. This is moving along in the House. Now look at this. A couple days ago, it was sent to Health and Human Services Finance Committee, and in red, where it will be heard on March 29th. That's today. It won't be up for a little while. The committee actually was supposed to start at 9 a.m., but it's way down the list. You can attend these, and I'm going to show you what it looks like. You have to get a little adept at reading the legislative website, but this is on their communications publications page, and you can actually find, here it is, the hearing, Health and Human Services Finance Division. Here's the date. You scroll down, and somewhere way down here, there it is, way down here, you find House File 3. The way you do this is you get to this page, you click on Channel 2, and you set it aside over here somewhere while you're doing your other work and sort of pay attention to it until the debate comes up on House File 3. If you want to actually see what they're saying about it, don't just take my word for it. So you can attend those hearings without actually going downtown. That's the point. In the Senate side, Senate File 1080, remember it's got to pass the House and Senate, and it's got to be identical. Remember that the House is controlled by the DFL, the Senate is controlled by Republicans, 35 to 32. There was a little worry when it was 34-33 that only one member would have to flip and they could get this done. Now it's a little more difficult. It's unlikely to pass the Senate. It doesn't mean it won't, but it's unlikely. So this is where you have to engage by calling your House member, telling them your feelings. If you support this, do that. If you don't, you're going to have to say, hey, let's go slow. We're not all for this. Agents have better plans. Now, you don't know, and call your senator and say, stand tough. On our MEEDAH website, again, I'll take you back there. There's a page called Contacting Us. It's under the Contacts file, Contacting Legislators, and it shows you how to do this. This is really a cool tool that links right to the Minnesota Legislative website. So here, you can type in your address. I'm going to type in mine and watch what happens. I've done this a few times, so it comes up with your House member, your senator, your state senator, your U.S. House member, and the 2 members of the U.S. Senate. So if I wanted to call Tim Mahoney, and he knows me pretty well, all I do is click on that contact from that Finder site and look at this. I've got his phone number, I've got his email address, I've got his legislative aid, and I can call and leave my message. It's actually a pretty cool tool that they've given us to be able to do this. So, but you can find that link on the MEEDAH website. We tried to create something that was really useful. Now, what about reference-based pricing? Now, I'm going to take you back to MEEDAH just for a minute, and then I'm going to show you why I'm doing it in this context. If you haven't gone here yet, to reduce the cost of healthcare, that's why we created this. This is created by myself, by Greg Datillo, and by a whole bunch of other agents and consultants who are concerned about what we're doing. Minnesota employers and employees demanding affordable healthcare, working together to convince legislators to do the right thing for working people. This is really important that you understand. We're trying to stage this as an argument for working people. Working people are the ones who pay the bills. And so you can find out who this is all about, scrolling down, and 3 specific articles that we've created to help explain what's going on, the 87% hidden healthcare tax, other fixes, 4 fixes that I think I alerted you to a couple of weeks ago, and then reference-based pricing. I'm going to go to that in a minute. Here on this page, a little bit of rhetoric about working people, and then comes our coalition members list. You'll notice you might recognize some of these names. We want this list to be long. If you support the ideas that we have, this doesn't cost you anything other than telling me your name, the name of your business, and the city. Send me an email and tell me I can put you on the list. If this list gets to be hundreds of names long, that's pretty cool, actually. And then a little bit about Greg and I, that's not important. Stories about the secret healthcare tax, the new price transparency law, hospital-acquired infections, that's all on here. You'll find this great chart here that explains how the new transparency law works. Over here, we have 3 articles that are very, very important about healthcare and about, here we go with reference-based pricing. In this article, how would you like to have, this is what reference-based pricing will do. We're going to have to find a sexier way to describe it. I don't know, we might call it the Great American Health Plan or something. Okay, that's a joke. I don't know what we're going to call it, but this is not us. This has been reference-based price insurance is already being used in Minnesota and elsewhere. We just need to acquaint agents with it so you can acquaint clients with this. Provider networks eliminated. You choose any medical professional you prefer. Insurance premiums lower, more money for other things. Annual premium increase is minimal. You know the price of care before you receive it. Why? Because it's paid on a percent of Medicare. And you can ask the provider to tell you what that is. Choose based on quality, free to build a relationship with a doctor. You're in charge, not the insurance company. This is what we're telling working people now. And because it's true, medical professionals have to compete for business, the type of insurance that won't collapse the healthcare system like Medicare for all. Now, that's the really quick once-over. Go on the MEEDAH site, go to Healthcare 2020, pull up New Way to Pay, and look at this. There's even a teaching webinar, if you will, that we've done on reference-based pricing to explain it to you. The products are available here. They're scant. There needs to be a lot more work. As more and more agents get interested in this and start asking, we're going to have more information. I think probably this is a good thing just to stay in touch with us on, because right now I can't say go to such and such an insurance company. So use the articles that are available on the agent's page. Share those with employers and clients and join the list on the About Us page. I already showed you this. So I told you it was going to be a quick one. My goodness, it's 27 minutes. I'm happy to take questions from you. I'm going to do something really scary because I've got you all muted right now. Do I dare unmute you all? I'm going to do it. Oh boy, it's gotten noisy. Maybe I shouldn't have done that. Is there anybody who wants to speak up with a question? Okay, I think that's going to get kind of messy. You know, I'm going to have to learn how to use this raising the hands feature so you can ask questions. You can use the chat and send me your chat questions. And I don't see anybody doing that, which is okay. Very, very okay. I have recorded this and I can make it available. There's my phone number. This is the MEEDAH office, and that's how you reach me through email. We're going to continue this. Boy, I really, really encourage you to go to MEEDAH and get a copy of House File 3. Spend a little time going through it. Feel free to email me if you have questions about it. Okay, when would the change, this is someone asked, when would the changes, okay, good, now we're getting the questions. Does this eliminate group coverage? I think by extension it does, and here's why the logic is if the ONEcare buy-in is allowed to pass, it's a platinum plan, it's going to have premiums significantly lower. What would be the impetus for small groups to continue to provide health insurance since it's not required under the law? This would be, I think, an incentive for them to break up their groups and go to individual coverage. I do remember there's a statute that says that they're limited in how they do that. We'll have to research that. But I do think that it would eventually cause the demise of the group market. Secondly, when did the changes start to take place? The serious one, the ONEcare buy-in, is January 1, 2023. So this is 2020, right? Or 2019. I mean, if it passes now, they've got a couple of years to get it up and running. That's the way it goes. It takes that long to develop. Be ready for this, the tools on MNsure that are going to work flawlessly to enroll people in this plan. I spoke at a group last night where there was an employee of MNsure, and wow, you should have heard should have heard her go off at the end about what goes on in that office. It's something I don't know that I should get into it. And for those of you who did come late, I do have this recorded. I think I should be able to make it available to people afterwards. So I don't see any messages, any other questions coming through. Oh, I know that. A person just said Minshir's not able to manage the enrollments they have incoming now. How are they going to manage more? Well, they're going to staff up. How many? It was like 53 new slots or something that they were applying for. Minshir. Yeah, Minshir. Someone asked, can we link MEEDAH.org to our own websites? Absolutely. I encourage you to do that. That'd be great. Please let me know if you've done that. So I know, I mean, it just encourages me to know that people are doing things. So yeah, Minshir, not MinCare, Minshir. Okay. Any others coming through? I apologize for not letting you speak up on, by unmuting you, but it's a noisy mess. And there is a way you can raise your hand, I guess, so I can recognize you. Maybe next time I'll actually learn how to do that. Any more questions? All right, hearing none, I'll entertain a motion to adjourn. Oh, here's one. Oh, someone asked, did a Minshir employee indicate they were cutting back? Absolutely not. Oh, is it modeled after the Massachusetts plan from a few years ago? I was thinking about this. We used to do a lot of research on the connector. I don't think they had a plan like this. I know that agents in Massachusetts, when the connector was built, did not sell individual plans. They were more concerned about the small group offerings that were on the plan. And I know that Massachusetts did have a plan, a cut rate plan. Thank you for that reminder. We'll go back and see what's out there now, what they're offering. One of the ironies of this, by the way, the name ONEcare, I think they chose this because Medicare for All is a political liability. The optics aren't good on it. So they use the word ONEcare. Well, that happens to be the name of the California single-payer system that actually has passed several times and never gets implemented because it's too expensive. I don't know if the people who fashioned this legislation know that they're borrowing a term for a single-payer system from California. I think that's a bad option for them. Any other questions? Will this plan require enrollees to term and move to Medicare when they turn 65? Oh boy, was there something in there on Medicare? I'll have to scan that. Other states with a similar plan. I'll have to find that out. Thank you for asking the questions. Yes, the ACA did grow a lot of jobs in both for government and in private industry. I mean, think of all the IT jobs that were created by trying to come up with the perfect electronic health record. And how's that working out? A couple more minutes, maybe. We'll see if any more other questions come through. I think the idea, Gene, is that they're going to pay less. They're not going to have to pay. If ONEcare is established, they're going to pay less to providers. They think that saves money in the system. That makes the insurance cheaper. And it saves money for healthcare in the overall spend. I suppose that's the thinking. With reference-based pricing, by the way, and I hope you do go out and look at that teaching video. It's only about 20 minutes. We actually can bring pricing discipline to the market through transparency, and that's a far better. It's a far better alternative. But we have to popularize it. We have to keep educating, and we have to keep asking for it. Oh, and I forgot to mention, golly, so much. There is a bill right now that's been drafted to establish reference-based pricing to make sure that it's allowed. And yes, it would be a step toward single payer, I'm sure. Yeah, okay. Yeah, that's right. I can see some of you are pretty excited right now. Um, Listen, y'all, I really enjoyed this. I'm happy to continue doing this. Let's stay in touch. Please send me emails with your inquiries. Remind me of the questions you need answered, and we'll work on that. I'll make this video available to people who want to watch it again or people who didn't get to come yet. You have a great day. God bless you and God bless America.